It's nice to meet you if I've met you before. I'm Karim and I'm an ACP Trainee Committee member, and I'm chairing this session alongside Lucy, who is the London rep, and I'm the South East Scotland and Edinburgh rep. So the webinar today is on Oncogeriatrics, and the first speaker today is going to be Mark Baxter, who is a clinical senior lecturer at the University of Dundee and is also a medical oncology consultant. He has got a really strong academic track record, having done a clinical lectureship before alongside a clinical academic fellowship, and he's previously been chair of the NOC Society, which is National Oncology Trainee Collaborative for Healthcare Research. He's primarily interested in geriatric oncology and improving the care in older adults, and his day-to-day job is looking after upper GI and HPV cancers. So on to you when you're ready, Mark.
Super. Well, thank you once again for the invitation to speak this evening. We're going to do a two-pronged attack, if that's okay. I'm going to give a little introduction to why geriatric oncology is important, and then also speak about the recently published Royal College of Radiologists guidelines on the topic. And then Kirsty's going to follow on and talk a little bit more about the nitty-gritty. So what is geriatric oncology? I thought it was good to start with a basic introduction. And put simply, it's the care of an older adult with cancer. And when we think about an older adult, we tend to think about aged 65 years and above. However, we must appreciate that not all 65-year-olds are equal. And certainly I work in Dundee, where often I'll see an inner city Dundonian who at the age of 55 looks more like 75. So a lot of the principles can also apply to younger patients. And these are some of the striking data from approximately a decade ago released by Macmillan. And at that stage, 60% of all cancers were in those aged 65 and above. And within that 65 plus age group, they accounted for 78% of all cancer deaths. And importantly, we lag behind other developed nations in overall survival for this older adult group. So there's certainly work to go. And thinking about the cancer action plan, and I know south of the border one is about to come out, but in ours in Scotland, there was not a single mention of an older adult within the whole document, which is quite striking. And we are all
Mark, I don't think your slides are moving on.
Oh, are they not?
It's still on title 1. Maybe
okay.
if you
Can you see that?
Yes, we can now.
Right. What I'll do you reckon if I move down? Sorry, everyone. How am I going to do this properly?
I wonder if you share at the bottom and go to the slideshow, whether that will work.
This one. Does that work?
No.
Disaster. Sorry, everyone.
Or if you just have to
click through them.
Yeah, I think that was working.
Is that okay?
That's perfect.
See that one?
Yep.
Yes, we can.
Perfect. Sorry, everyone. Blame NHS Tayside for this. So as I was saying, there's not a single mention of older adults in the cancer plan in Scotland. And when we think about the demographics of our population in the coming years, the population pyramid is on the right of the screen. And it's estimated that by 2043, 1 in 4 patients, or 1 in 4 people in the UK will be age 65 and older. And we know that age is the biggest risk factor for cancer. And therefore, it's likely that the number of older adults with cancer that we see in clinic is going to increase. So we're all geriatric oncologists, and we all see older adults with cancer, and therefore this is very applicable to us. At present, the median age of diagnosis is 73, and we'd anticipate with these demographics that this might increase in the coming years. And with the age, we know that frailty and comorbidity are common and increase with increasing age. And this is important because we also know that our older adults do receive chemotherapy, and both age, along with comorbidity and frailty, have an impact on outcomes with chemotherapy. And we also know that we've made rapid improvements in our treatment algorithms in recent years, and it's possible that our novel agents might be better tolerated and have similar outcomes with older adults. And we've certainly shown this with immune checkpoint inhibitors. And when we think about the patient cancer journey, and I've broken it down quite simply here, There are potentials for delays in deconditioning at all stages. And when we think about a patient presenting, they then undergo investigations and come with a diagnosis, then discussed at an individual MDT discussion, and then have an appointment with either an oncologist or surgeon in general, and a treatment plan is made. And we aim for this to be done in 62 days. Unfortunately, despite a target of 95%, in the most recent figures, we're nowhere near this. And as I've mentioned before, with each of these stages, there are impacts of deconditioning, and this also has an impact on symptom burden, as well as a psychological impact, the stress of waiting for a treatment plan, waiting for a formal diagnosis. And there's also a financial impact, and this is relevant to all patients, but particularly those older adults. And we're also increasingly thinking of cancer as a chronic disease or comorbidity. In many metastatic settings, the 5-year overall survival is significantly improved in the last few years, and that's due to the increasing range and number of treatment options that we have available. And actually, it's not uncommon for me to see a patient now in clinic where the cancer is just a chronic disease, and patients are more troubled by their osteoarthritis or their other comorbidities such as diabetic control. And this itself brings issues with long-term follow-up for older adults and the treatment-related side effects and their impact on outcomes, the psychological impact and fear of recurrence, and as I've mentioned, the management of other comorbidities as our patients age. And unfortunately, our older adults are more likely to present at an advanced stage. And data from Macmillan has demonstrated that older adults are more likely to need more GP appointments prior to being diagnosed. And there's a number of reasons for that. And again, this has been researched. Older adults are more likely not to want to not bother their GPs. They don't recognize symptoms, or their disease can present in an atypical way. So, for example, non-specific symptoms. And this can result in a misdiagnosis initially. And there's also, as I've mentioned, overshadowing by other health problems, which if you're limited in time in primary practice or in primary care, patients might choose to focus on their diabetes rather than their weight loss. And we know that when older adults have a diagnosis, they're less likely to receive all anti-cancer treatment, and that includes surgery, radiotherapy, and systemic therapy. And this is just some data from gastric cancer from the International Cancer Benchmarking Group, but it's the same across all tumour groups. When we look at age and the percentage of patients receiving chemotherapy on the y-axis with age on the x-axis in groups, we can see with increasing age, chemotherapy delivery decreases. And it also shows that England in the blue, Scotland in the grey, and New South Wales in Australia, that we give less chemotherapy than other developed nations. So there's certainly work to be done. And when a patient eventually reaches us in the oncology clinic, frailty is common, as I mentioned before, and this baseline frailty predicts poorer outcomes. And this is just some data from our TOASTY study, which we published last year, which prospectively recruited 339 patients being lined up for first-line chemotherapy who were over the age of 65. And the median Rockwood CFS was 3 with a range of 1 to 6, and only a third of patients had an ECOG performance status of 0 at baseline. We noticed that polypharmacy was common, and the baseline frailty score predicted severe toxicity. So in those with a CFS of 4 or more, their rate of grade 3 toxicity was significantly higher than if it was a CFS of 1 to 3. And importantly, our delivery or our explanation of risk to patients was noted to be problematic. And I say that because when we looked at the clinician's perception of risk and the patient's perception of risk, there was a big difference and very poor correlation after an initial oncological clinic appointment. And I just highlighted the box in red, which is the group of patients where clinicians felt they were at very high risk of severe side effects, but patients actually felt their risk was low. So there's work to be done on how we communicate our risk of treatment with older adults as well. And I'd just like to stop and just highlight the people on this slide who were pivotal to the recruitment in the TOASTY study, and I just wanted to do that because several of them may be on the call, and just thank them for their help. And this frailty also has other impacts. As I've mentioned, it's associated with increased severe toxicity, but is also associated with more hospital inpatient days, more hospital days in hospital in the year following an intervention, and also an increased risk of dying in hospital. And this is using electronic health records in England, a study by Tawhid Imam from a few years ago. And it's interesting because it demonstrates that patients aged over 75 are receiving chemotherapy, and they're also receiving chemotherapy at this age, even with severe frailty. So again, we need to identify those at high risk and try and intervene if at all possible. And the ultimate result is that our older adults with cancer have poorer survival. And this is just some data from NHS Tayside from my own research over the last 10 years with around 30,000 cancer diagnoses. And when we look at survival probability on the left, time in days on the x-axis, we can see that even in the first year of following a diagnosis, the survival of older adults is significantly worse than younger. So putting all of this together, how can we support our older adults with cancer? Well, this is the document I alluded to at the beginning of the presentation. And it's the Royal College of Radiologists guidelines about implementing frailty assessment and management in oncology services. And this document, which is available as a PDF online, highlights the importance of frailty screening, provides a framework for how we can go about doing this, and also gives example of best practice and recommendations. And it was a JCCO working group that was put together, and the guidelines were developed in conjunction and association with several organizations, which I've highlighted in this slide. And the contents are broken down into 5 main chapters. The first one being the introduction, the second, frailty assessment in oncology, third, management of frailty, fourth, thinking on education, research, audit, and service development, and then the fifth being some recommendations. And there's also some useful resources in the appendix. So thinking about this talk, I'm going to try and break down, and I know Kirsty's going to speak a little bit about frailty and why it's important, so I'm not going to focus too much on this, but the focus of frailty assessment in cancer care is 2 broad aims. The first is to help gauge the potential risks and benefits of anti-cancer treatment, and also inform shared cancer treatment decision-making with patients. And it's also to allow identification and optimization of frailty-related issues. And this is the potential to improve patients' symptoms, quality of life, and tolerance of anti-cancer treatments. And broken down, the guidelines looked at who should be assessed, when we should be doing it, who should be doing it, and what should be done. So thinking about who we should assess and screen, we advise within the guidelines all patients aged 65 or older with a suspected or confirmed cancer, but we can consider it in everyone. And importantly, any appropriately trained healthcare professional can perform the assessment, so it doesn't have to be us in oncology clinic. When should we assess? This is a figure taken from the guideline. And importantly, it highlights that we should assess before a management decision is taken, but ideally during, as many times during treatment and at regular intervals as possible, so that we can pick up a change. And again, breaks down what is considered as pre-frail, mildly frail, and moderate and severe frailty. Then thinking about how we should do it, the key point that is stressed is there's no point in assessing frailty if you're not going to act upon it. So it's important that we take the frailty screening and the results from this on board and try and adapt our treatment decisions, but also try and intervene where possible. And a 2-step approach is recommended. The first is a simple frailty assessment or screening. And the purpose of this is to identify the patients likely to benefit from a more comprehensive assessment. And it should be used to complement usual oncological assessments. So this isn't used to replace ECOG performance status, but more to be used in conjunction with it. And there are many examples of these frailty tools, and I guess the most commonly thought of one is the Rockwood Clinical Frailty Scale. But there are also other tools that you can use based on your own environment and what's suited best for your patient cohort. So for example, clinician reported like the Geriatric 8 or the SAOP3, or self-reported. Again, there's a self-reporting Geriatric 8 version, as well as a VES 13 and a self-reported SAOP3. And there's also the ability to sometimes use electronic frailty index, particularly in England, where it's available from primary care. And based on that results, we can think of a comprehensive multi-domain frailty assessment. But again, it's very much dependent on what's feasible in your environment to the value it will add, and it's important to balance this up. And we must stress that this involves significant allied healthcare involvement. And the main goals of all of this is to optimize our decision making, weighing up the benefit of treatment and the harm of treatment, and trying to come up with a plan that is best suited to the patient in front of us. And we also want to address any reversible frailty related issues, thinking about the domains on the right. So comorbidity, functional impairment, psychological issues, nutrition, polypharmacy, social issues, cognition, and ultimately the cancer as well. And then moving on to the fourth section within the guidance, we mention education, research, audit, and service improvement. Over recent years, there's been an improvement in the resources in terms of the availability of training for geriatric oncology, and a recent study that we looked at all postgraduate curricula, and there's not a single mention in any postgraduate medical curricula or surgical curricula of older adults with cancer. So there's certainly work to be done both in the undergraduate and postgraduate realm in order to try and improve our education. We need to make sure our future research and our current research is both representative of the patients we see in clinic, and not exclude patients in the clinical trials that we have open just based on age. Because the reality is that we are seeing people in clinic who are almost a decade older than our pivotal clinical trials, and we need to find a way to redress that balance. And thinking about our existing geriatric services and trying to develop the need when you're thinking about putting together a business case, it's important that we do audits to try and demonstrate our clinical need. If we do implement any changes, we find a way to evaluate this, and then we try and build business cases to try and develop dedicated geriatric oncology services. So putting all of this together, the key recommendations from the guidelines looked at an individual and local level and also at a national level. So at an individual local level, we proposed that everyone should have basic frailty treatment. We should assess, consider and manage frailty at key time points, thinking back to that figure from a few slides ago. We should empower the whole MDT and develop and link with specialist geriatric services. And we should try and integrate frailty assessments into electronic healthcare records, both to enable decision-making within an oncology setting, but also to be able to see change over time with treatment. And then at a national level, we need to make optimizing care and research for older adults living with frailty and cancer a priority. And we proposed that a frailty assessment such as the Rockwood CFS should be a key performance indicator and considered as a key part of 2-week wait referrals and MDT performance. And I'd just like to finish by highlighting the frailty working group again, and also this QR code, if you're interested, will bring you to the guidelines directly.
Thank you, Mark. That was incredibly informative, and hopefully we can have some discussions about guidance and going forward and how we could utilise that in our own practice. I will now introduce Kirsty. So Kirsty is currently a medical oncologist based at St Barts Hospital, and she's specialising in genitourinary cancer at the moment. But she has a specialist interest in geriatric oncology, and that initially started at Guy's when she was one of the Gold Fellows in 2022. She subsequently went on to launching an older adult service based at Chelsea and Westminster, and she had ongoing clinical lead duties as part of that. She's now based at Barts and hopefully is looking to introduce a similar service at this hospital. So I'll let you take it away, Kirsty.
So yes, thank you very much for the introduction. As Lucy said, I'm a medical oncologist working at Barts, and Mark's kind of talked about the whats and the whys, and I'm going to talk a bit more about kind of the practical aspects, a bit more about frailty and about service implementation, and then if we have time, we'll go through a case. So Mark's talked about why we offer specialist assessment for older people. I want to dwell a little bit more on kind of screening and what actually comprehensive geriatric assessment is. CJ is bandied around a lot, and I think as oncologists, unless you've had some geriatric experience, it's hard to know exactly what this means. So we've described this silver tsunami, this rapidly expanding population, for these three different reasons that you can see. But I think the thing that's striking, although, as Mark says, educational opportunities and resources are increasing, back in 2013, Tanya Kelsey, who runs the Gold Clinic, the Geriatric Oncology Liaison Department at Guy's Hospital, did this survey and showed that 66.1% of oncology trainees had never received training on the needs of older people with cancer. And I always enjoy this stat. So 81.4% felt confident in assessing and treating younger patients, but then that plummeted all the way down to about 10% when you factor in older patients, patients with significant multiple other medical conditions, and then those who are older with dementia. And although I think geriatric oncology has got a slightly higher place on the agenda and prominence in people's minds, I still think we probably haven't got to where we need to be in terms of focusing on it as a priority and an educational priority. So frailty, as we've talked about, is this loss of reserve, so this vulnerability to an insult or a particularly stressful event. It is associated with aging, although as Mark pointed out, it is not exclusively so. So it's very variable depending on biological age and other factors. I think, for example, across the country, there are significant differences in what counts as an older person. And for example, at Marsden and at Chelsea, we would use that cutoff at 70, but down in Poole, the geriatricians won't see anyone who isn't over the age of 80. So significant differences. And I think over time, and as frailty screening and assessment becomes more robust, we may eventually see a shift to using frailty indices rather than age ones. So we know that frailty has a negative impact on a number of cancer and cancer treatment parameters. And I think this for me is the best kind of pictorial guide of what a frail patient looks like compared to a fit one. It just takes, one last thing and everything comes tumbling down, be that a cancer diagnosis or treatment. And I think this illustrates that really nicely as well, in terms of the difference between your frail patient in the pale purple and your fit patient in the darker purple. And obviously the frail patient after insult 1 and insult 2 never quite recovers back up to their baseline and is then rendered dependent. So what's the data behind offering dedicated services for older adults with cancer? So the first publication in this table is data from Guy's Hospital. So this looked at patients who were over the age of 70, a cohort of patients who had comprehensive geriatric assessment as they were beginning SACT for a solid organ malignancy compared to a group who did not. And then the following trials are all randomized control trials published in 2020 and 2021, which followed a similar kind of format in terms of trial design. And the overwhelming findings from these studies were, first of all, a significant reduction in significant toxicities, a reduction in modifications to treatment, so a reduction in delays, omissions, and reductions, critically decreased emergency admissions, and then overall increased treatment completion rates and improved reported quality of life. So if we move on now the screening, I think, is something that is really well done, and increasingly so by other parts of the hospital aside from our geriatric colleagues. But I think we clearly as oncologists have room for improvement. Often people ask, what is the best screening tool? Mark kind of mentioned a few of them, and I think the consensus generally is the one that gets done. Anything that promotes the screening and identification of patients who are frail or at risk of frailty has to be a good thing. The clinical frailty scale, the CFS, based on Rockwood, is available now through electronic patient records at both of the trusts that I work at. And I think some of the best adopters of the use of this have been our A&E colleagues, particularly with the rollout of front door frailty. It's been really helpful to see a snapshot in time of how frail a patient was deemed to be at that point. The other thing to point out is that these different screening tools, in one hand, I've said it doesn't matter which one you use, just use whatever will get done. But in the other hand, they have slightly different focuses. So, for example, the G8 has got a much heavier emphasis on the GI side of things and nutrition. But equally, it's possible to create your own. So at Guy's, they use the CRANE tool, which is the comprehensive risk and needs evaluation. So it's possible to tailor one of these so that it really fits the needs of your population and identifies kind of common problems. The other one to point out is the SEOP3, so the Senior Adult Oncology Program 3, which was pioneered by the Moffitt Cancer Center in the States, which I think has the oldest geriatric oncology service, or certainly one of the most established internationally, and several other services use that in addition to a quicker screening tool like the CFS to provide a slightly more comprehensive screening, which then enables patients who are coming to clinic to have, well, given the teams who are going to see them a much better idea of which domains they're going to need assistance with. So this is the CFS for those of you that haven't seen it. It's very simple, a score from 1 to 9. It comes with pictures. There's an app that you can get on your phone. So if you're not clear from looking at the description of the pictures where a patient sits, you can put in various characteristics and it will come out with the score for you. So moving on to comprehensive geriatric assessment, it has a long technical definition, but essentially it's really simple, and it's this 4-step process of screening patients, a more in-depth assessment, coming up with interventions or recommendations on the back of your assessment, and then following them through. So to give you an idea of CGA domains, and this is not exhaustive, but the typical things that will be covered in this are things like comorbidities, geriatrics specific syndromes like continence or falls, polypharmacy, a really common one, physical function, cognitive impairment, mood, and obviously kind of social circumstances of each patient. So this is, again, not exhaustive, but it's just to give an idea, and I'm not going to go through this whole table. But if we pick a couple, so for example, fatigue, there are many reasons, for our patients to be fatigued, not least their diagnosis and the anti-cancer treatment they're receiving for it. But that doesn't mean that they're exempt from other causes of fatigue. So important to kind of think outside the oncology box and remember to check for thyroid disease. Are they anemic? Is there a kind of psychological aspect to this? But then also offer coping strategies. So things like pacing strategies, a fatigue diary, so that patients can work out which days are going to be better for them and plan events accordingly. Similarly, bladder. So I treat prostate cancer, as Lucy mentioned. So this is very frequent, but making sure that if things have got worse, a patient doesn't have a UTI, educating about pelvic floor exercises, well done, well, relatively well done in women, much less so in men. Advice about double voiding, and then obviously kind of giving toilet cards so that people can use a public toilet in an emergency. And I could go on, but I think these, and for example, antihypertensives, so many older people have been started on an antihypertensive in the past, but actually now their blood pressure's in their boots. It puts them at far higher risk of falls. So it is a really systematic way of going through all of these things. And I tend to, if I see a patient in clinic, I will start with their comorbidities and literally list them out, and then go through a set of other systems in order. So models of care. Fabio Gomez led a publication in 2020 that looked at the state of geriatric oncology services across the UK at that time. And then there were 14 centres. That was updated at the end of 2024, and there are now 27, which is a great increase in that time. And there's already, as well as these 27, far more kind of other fledgling services that are being developed. So this is the model of care that we use in Chelsea and Westminster Hospital, and I've obviously used my experience from the Gold Centre at Guy's, so there are many similarities. Essentially, at Chelsea, we take patients who are over 65 or somewhere between 65 and 70, but with some flexibility, given the discussions we had before, that have a diagnosis, a starting anti-cancer treatment, and are either frail, vulnerable for frailty, or have other areas of concern, be that comorbidities or something else. We take referrals directly from the oncology treating team, and we ask at that point that a clinical frailty scale score has been completed, and also that patients have been given the SAOP3 screening tool, so that we've got an idea in clinic of who of our team may need to be involved. So our team comprises myself, a geriatrician, clinical nurse specialist, a physiotherapist, an occupational therapist, and a pharmacist, which is a great, it's a great team. It's very well resourced. I know other services also have dietitians and speech and language therapists, but as we can go on and talk about a bit more later, it doesn't need to be an all singing dancing team. We're very lucky, but actually any healthcare practitioner can offer some form of geriatric oncology. So patients come and see us in clinic. We go through comprehensive geriatric assessment. As I said, we will tailor the appointment depending on what needs the patient kind of brings up. And then we also discuss them in our MDT. And following that, we will draft, we will come up with a series of implementations that are needed, put them into action, ensure that any onward referrals are undertaken, and then make sure that we feed back our recommendations both to the oncology treating team and also the GP. I think communication with the community is really paramount, and I think as a specialty going forwards we need to look more closely at how we dovetail even better, particularly with the emphasis on moving care closer to home. So if we talk now about, we'll see how we do for time, but a couple of cases. So this is an 86-year-old gentleman who has a diagnosis of a T3N0M1A sigmoid adenocarcinoma. So he's got multiple liver mets, with the largest one measuring up to 5 centimeters. He's mismatch repair proficient, RAS wild type, and so he's seen an oncology clinic, and the plan is for FOLFOX and panitumumab with palliative intent. This is the outcome of Jeff's SAOP3 screening tool. So he said that he didn't have any mobility issues, was independent, had a bit of weight loss, and his appetite was a bit up and down. Again, some fluctuating fatigue. He did, however, in the mini-cog, so the mini-cog essentially is comprised of 3 different parts. One, recognition of words and being able to repeat them then and there. Recall later of those 3 words, and then being able to draw your clock face with your kind of 10 to 2 time or 10 past 11. He unfortunately only scored 1 out of 3 for this, and actually reported that he had long-standing memory issues. His quality of life he reported as being 7 out of 10. And then I think this is a really key question we ask all of our patients, and I know a lot of centres do, but asking them what matters to you, what are their priorities for treatment or not treatment, what are their long-term goals. And Jeff interestingly answered at the age of 86, living for as long as possible, I'm curious to see what the future holds for the wider world. So in terms of comorbidities, not a huge amount, to be honest, for Jeff. So hypertension, hypercholesterolemia, he had celiac disease. on an antihypertensive, statin, and then on amitriptyline and cetirizine. No dotted box, but mentioned that he was beginning to struggle, given that he'd started SACT with a number of supportive medications. So his CFS score at that time was 3, so he was managing well. And the recommendations based on these factors were that obviously a dotted box would really help him out, to review his statin and consider deprescribing it, a secondary prophylaxis. And the other thing was to review his amitriptyline and cetirizine. So anticholinergics, not great for older people, both in terms of cognitive effects and also risk of falls. So if you can identify an alternative, always worth doing. And there's a really helpful online calculator, the ACB, the Anticholinergic Burden Calculator, which was great for giving you a score of your drug, and then you can work out if you decide you want to prescribe an alternative or not. And then for all of our patients, obviously he's on an antihypertensive, but what is his blood pressure now? Does he need it? So Jeff's pretty fit. He cycled to the station and locked his bike up outside before getting the train to clinic. So he has no mobility kind of needs at the moment. He described obviously his appetite as being not as good as it was, and he's lost a fairly significant amount of weight over the past couple of months. His cognition, however, has been a much longer term issue. So for years was his description. And he'd had an MRI brain, which basically showed no problems from a metastatic angle, but had showed parenchymal atrophy with hippocampal involvement. And our occupational therapist went on to do a full mocker for him, and he only scored 21 out of 30. So there was clearly impairment there. And I've put on the slide the areas that there were deficits noted in. So the recommendations were to refer to memory clinic. Memory clinic is really helpful particularly for patients who don't have a huge deficit where there is scope for some improvement. But also, again, there are things that we can tell our patients that they don't need to go to memory clinic for. For example, things like setting timers on their phones, how to help with remembering medications, those kind of memory prompts and things like that, so that they can just change their behaviours to help compensate. Dietary advice, again, the knee-jerk reaction is to refer to dietitians, which obviously happened, but in that interim, little and often, he's only eating 2 meals a day. That's clearly not enough. So trying to focus on kind of increasing the frequency of his eating and the calorie content of that too. Fatigue, so he did have some fatigue, but actually because he's so fit, he was still very, very active physically. And then hearing, he was really cross that actually he'd got significant impairment. He tried to get hearing aids in the past, but hadn't got on with them, and it was significantly affecting his interactions. And I think this is one of the take-home points in terms of it's not really adequate to assess someone's cognition if they can't hear, and it has so many knock-on effects throughout all of their care and their ability to interact and the way they're assessed, that's actually a really key thing. Vision, he essentially had some early cataracts, had been seen by the optometrist recently, and at home actually he was very independent, was living alone in a 6th floor flat, and didn't need any assistance there. In terms of social support, he had some family who were several hours away, but had already worked out his health and welfare lasting power of attorney. So that had been sorted, but not the financial side of things. So here, of course, our occupational therapist discussed fatigue management with him, as I kind of alluded to before. Loneliness is a really common problem, particularly amongst our population. So signposting to various social groups and befriending services, helping him out in terms of being reassessed for his hearing aids, highlighting again to the GP that the cataracts were there because prior to that hadn't been communicated, and then also highlighting to the family and Jeff that they should consider in terms of finalising his affairs, property and financial lasting power of attorney. So Jeff then completed 12 cycles of Folfox and panitumumab. And at that point, he was rediscussed at the MDT because he'd had a pretty good response to treatment, and it was then deemed that surgical management was technically possible on the basis that his liver metastases had shrunk and were amenable to ablative treatment, and that he may be a candidate for surgery now. He then had a bit of a treatment break, primarily because of toxicities and also for quality of life. And then he restarted treatment and was worked up for surgery. He had his liver ablation in the autumn and then was planned for a robotic anterior resection. And then he was actually re-referred to the geriatric oncology for prehabilitation. So I should have said at the beginning, we run a one-stop shop. So we describe it to patients as an MOT to try and optimize, but also assist with treatment decision-making at the start of treatment. But very occasionally, we do offer a second appointment if something has changed, or, for example, there would be benefit from a repeat review. So Jeff came back to clinic and he was seen primarily by our physiotherapist to offer him some strength and balance exercises to aid him through his surgical procedure. And she was great at giving him things that he could do at home, giving it all in a kind of written format that he could follow. And our geriatrician also saw him at that time for repeat cognitive assessment, and given the high risks of delirium in this population, put in some prevention strategies and assessments around that too. And then Jeff proceeded to have curative surgery later that year. So that was a nice case of someone who was pretty, in some ways, fit biologically, but had some significant other issues, but actually with some comprehensive geriatric assessment managed to get through sufficient chemotherapy to open up some more radical treatment options for him. I've got one more case, Lucy. Do you want me to do it, or are we kind of good for time?
I think we're good for time. You can go ahead. Yeah, yeah. Very interesting. So let's do it. Yeah.
Okay, so the second case is a lady called Margaret. So she's a 77-year-old lady who had a left breast lobular carcinoma, triple negative, T4B N1M0. And so the standard of care for her was carboplatin and paclitaxel for 4 cycles, followed by epirubicin and cyclophosphamide with pembrolizumab neoadjuvantly. And then there was a plan for mastectomy with axillary clearance and then adjuvant pembrolizumab. So fairly potentially toxic treatment. So we've talked, well, Mark mentioned about the kind of lack of evidence in this field. And one of the key things is toxicity prediction. But actually CARG, which is the Centre for Aging Research Group based in the States, has a chemotherapy toxicity prediction tool and one that's specific to breast cancer. So I kind of pasted what the results would be for Margaret on the slide, but essentially for this chemotherapy regime, you put in a number of, 8 different parameters based on tumor features, treatment, and kind of biochemical and then functional factors, and then it comes out either with a low, an intermediate, or a high risk of significant toxicities. Margaret scored 5, so she is at the upper end of what's known as the low risk category, with a rough estimate of 25% of greater than grade 3 toxicities. So her SAOP3 came back with polypharmacy, so she takes more than 5 regular medications. She has a bit of decreased mobility due to some right knee pain, has lost interest in kind of social events and is not sleeping particularly well. Mood was a bit of an issue for Margaret. No cognitive impairment, quality of life 6 out of 10. And what mattered to Margaret was maintaining her independence. So in terms of past medical history, again, nothing hugely dramatic. The right knee arthritis that's obviously causing her this pain, but also bipolar disorder, which had been very well controlled for a long period of time off treatment. Medications wise, I think the point here is also to ask people, obviously it's prescribed medications, but also what are they taking over the counter as well, and going through those. And again, her CFS was 3. So on reviewing clinic here, we tried to optimize her analgesia because clearly what she'd been taking wasn't sufficient. There was also a clear plan when she was going to receive steroids that we needed to monitor her mood very closely and obviously reduce or omit doses as needed. And then the blood tests on that kind of penultimate line of the slide are a fairly standard set of kind of geriatric oncology blood tests that can be useful for screening for all of the things that are there. And again, checking her blood pressure. So mobility wise, she did have an antalgic gait, but was walking unaided, was very independent, lived in a ground floor flat, and otherwise used to run a commercial cleaning company, lived with her husband, and was well supported otherwise. So she had strengthening exercises for her right leg given to her, was given advice and directed to other exercises that would be appropriate given her kind of impairment at the time. And then otherwise, we talked a bit more about the kind of social side and what had affected her. And really, it all came back to mood for her. So she'd really disengaged, and her geriatric depression score was 6, suggesting that she did have mild depression. She was again fatigued, which was made worse by insomnia and her mood. So this kind of multifactorial aspect to it. So again, she was given fatigue management and pacing strategies, which I think is probably one of the most common things that our occupational therapist does in clinic. Again, social prescribing, given advice on how to kind of reintegrate herself back into things that she felt that she was missing out on. And we also asked her GP to provide ongoing support in terms for her mood, and again signposted her to cancer charities that offer counselling for patients with cancer. So just to finish up, I think clearly geriatric oncology is a field that is increasing and becoming more well known. There are a number of bodies that have offered significant support, and ASCO, for example, published guidance in 2018 stating that all older people starting treatment for cancer should receive comprehensive geriatric assessment. In terms of groups to become involved in, if anyone is interested and wants to find out more, the National Forum of Oncogeriatrics is a, well, as the name suggests, is the UK group, and it's a very friendly group with allied health professionals and medics from all over the different centres across the country. And then SIOG, the International Society of Geriatric Oncology, is again a really friendly international group, but there is also a UK special interest group, which again is very active as well. I think that's it for me. Thank you very much.
Thank you, Kirsty. That was brilliant. So I think we can move on now just to see if there are any questions. I don't think there were any in the chat, but if anyone would like to write any questions they have in there, and perhaps while maybe I kick off, and I suppose this is a question to both of you. Obviously, these assessments that you've said, anyone is better than none. If we were to conduct them in clinic, so we don't have a comprehensive service, how do we deliver geri-onc kind of whole person care approach if we're limited with the resources that we have? So if we don't have our occupational health, a colleague or our pharmacist to support us, is there a concern that you do the assessment and nothing happens? And how can you stop that from being the case?
Shall I start, Mark? So I think it was the lead of the WHO who I think said previously, not in relation to this, but what gets measured gets done. And I think there definitely has to be, if you're aware of a risk here, that's going to make you practice differently, even if you don't have access to an entire team of therapists. I think the model that I described is something that is great if you can access it, but it's clearly something that isn't possible in many places. And actually, even at Chelsea, we're looking now at we're using charity funding. We're coming to the end of that, and if we don't get the same again, we're trying to look at what aspects we can use. So for example, we're looking through all of our SAOP3 tools to work out for our population what are the most commonly reported issues that people need help with, so that we can work out, if we do get any form of funding, or even if we don't, which areas we need to be able to signpost patients to, and work out new pathways that don't necessarily come through a comprehensive geriatric assessment approach. And then I think the last thing is, as oncologists, it's really difficult in a busy oncology clinic to look at all of those things sequentially. But over time, I think there are things to be mindful of, and I think there are sometimes really there are quick wins. So I think the quick wins are things like mobility. Have you had a fall in the last year? Yes, no. That's a really 2-second line. A mini cog probably takes about 2 minutes to do, and then gives you a really instant screenshot of whether someone needs further assessment or not. Blood pressure. So I think it's just having a little framework in your head of working out, be it 5 key things that actually will make a big difference clinically.
I'll jump in now. I think it's a really good question, and I think there's different models of care that are suited to different resource settings. And I guess Kirsty comes from a high resource setting, or a fairly high resource setting, whereas I come from a low resource setting whereby I have very little support in terms of doing this. And I think just doing something is better than nothing. And I think if I was to pick 2 things, it would probably be the Rockwood CFS. And that is just to be used as I guess, a guide for toxicity of treatment, but also good correlation with survival as well. I deal with a very poor prognosis cohort of patients with HPV. So actually being able to have an upfront and frank discussion about their goals of therapy is very important. And that's why the first question I always ask is, what matters to you? And you'll have an older patient come in and say, I want to live as long as possible. I've got my 80th birthday next year, etc. Or somebody who says, I want to avoid hospitals, I hate it. And I want to maintain my independence as much as possible. So I guess if there were 2 things that I would recommend, it would be asking what matters to you as your first question, and then doing the Rockwood CFS. But locally, I guess, if you're trying to improve your service, I've designed, I guess, a screening questionnaire that patients complete prior to seeing me in clinic. And it covers some of the things that, such as falls, such as symptom burden, that can indicate frailty or drive it, and avoids the patient who puts on their makeup and their best clothes to come and see you, and gives a better reflection of honesty. Because patients don't often tell us the truth regarding what the actual reality in real life is. So hopefully that's helpful.
Yeah, that is. And I think the example of Jeff, when there were some things that were uncovered which perhaps weren't realised and perhaps weren't completely realised by the patient, is a very good example of that. If I just read out this question, there's a great question on the chat. So someone's talked about the results of the GO2 trial, and it's about dose reducing chemo in upper GI cancer. They've queried that they've got that right. And that didn't lead to worse outcomes, but actually increased tolerance. And so they are wondering if there's evidence for upfront dose reductions of systemic treatment in other tumour sites. And I think my experience from GI, that we tend to have a bit of a blanket approach. Yeah, what's your experience with those, and is there any guidelines or things that we could follow to?
Should I go first, Kirsty? Ben, you've got it absolutely right. My PhD was actually looking at the GO2 trial. So no, you're absolutely right. So it was I think the UK has been a leader in terms of dose de-escalation strategies. So there was the Focus 2 study led by Matt Seymour in Leeds, and then he subsequently designed so it was in colorectal cancer, looking at dose reduction. And then it was the 3-2-1 GO study, was the precursor to the GO2 trial in gastroesophageal. And there was a study published last year and presented at ASCO in 2024 called the GIANT study in pancreatic cancer, which demonstrated the feasibility of giving 80% Gemabraxine fortnightly to older, frailer patients. And that's actually an approach I now adopt for sort of older, frailer patients with metastatic pancreatic cancer. And it's better tolerated and is nicer in terms of hospital visits. So yeah, there are an emerging field of, I guess, non-inferiority trials, but they're not glamorous. So they're all academic as opposed to industry-led, and funding is challenging. So yeah, there are examples.
Yeah, I think that last bit is a really key thing about the field, isn't it, Mark, in terms of it's not the sexiest of fields in terms of the traction that it gains. I think Mark's covered the tumor types that do have evidence. There's obviously still a whole host of tumor types that don't have evidence, and I think for those it can be really challenging. But I think the fundamental principles of you can always escalate, but it's harder to come back if you have a catastrophic event early on, close monitoring of patients and close conversations with patients up front. So, making sure that we know about priorities. And I think that the table from Toasty with the kind of clinician versus patient's risk of perception of risk, just making sure that that's very clear before you start. I think in patients with breast and prostate cancer, the study that showed about 15% of patients had decisional regret related to treatment. So yeah, I think something that definitely needs to be ascertained early on.
And just coming, I guess, an extension, there's recent ASCO guidance suggests, I hope that's ASCO, I hope that's right, Kirsty, that start low and go slow in a way. So and I use that approach. If I have any concern about toxicity, I will start at a lower dose with the option to escalate. And I'm upfront and honest with patients, and they're very happy with that.
Yeah.
Because if you go too hard, then you can toxicity miss the window of dose intensity, etc.
Yeah. And I think that initial assessment that is so comprehensive is incredibly important in identifying those issues. So kind of uncovering that frailty. And I think perhaps in the population similar to, in London, where there are some patients that are frail and they're not necessarily old, trying to understand a bit more about them and their comorbidities is incredibly important, because that would allow you to guide that treatment.
And I think as well, just to add, there's something in the other direction as well. I mean, certainly from moving from down south to coming to Scotland, I'm surprised at how few patients who actually look surprisingly robust don't want treatment. I don't know if you find this as well, Mark. And I'm sitting there in clinic thinking, no, come on, you have to have something. And they're saying, no, nothing for me. I'm done, nothing for me. And actually, there's such a different approach up north of not wanting it, whereas sometimes I found down south I was having to fight not to give it. And I wonder whether there is something in that as well of our patients who are older doing worse because they don't want it or are less aware of their own abilities, and does a comprehensive geriatric assessment open up that to them more of an understanding that they're able to tolerate more than they think they are? I don't know.
Yeah, and I think an important point we haven't touched on is the biology of disease in older adults is different. So we have evidence from younger, fitter patients in whom their disease is different as well. There's a nice publication in Lancet Longevity a few years ago demonstrating different biomarker and mutational profiles across different tumor groups. So we may be giving treatments that aren't appropriate to our older adults, but we don't know.
Yeah. I'm just thinking of the recent ASCO publication, which was looking at structured exercise for patients, colorectal patients after adjuvant treatment. So I think things like that, again, just shows that for our older age group, then we have to think about that, because we've just talked about how perhaps we're making modifications for these individuals. But if we want to try and introduce those sorts of things, which now have evidence base, how can we incorporate our older age patients? How can we tailor it for them? Because otherwise, automatically, we're excluding them on the basis that, you write them off that they can't do an exercise program. So it requires a lot of consideration.
one of our talking about how we kind of go forwards at Chelsea, our physiotherapist is looking at exactly that. So she's looking at trying to run a dedicated exercise class for older adults with cancer. She has asked loads of our patients whether they would A, be interested in it, and the overwhelming response was yes, actually, and B, whether they would prefer it to be remote or in person, and they've all gone for in person. So she's in the process of trying to set that up.
It doesn't surprise me, that kind of community aspect to it. I suppose the question is that if there's anyone listening that is kind of interested in trying to start up a service, you know, they would like to take this on, because as you said, that there are increasing numbers of service in the UK, but they are few and far between. What would you advise from both of your experiences and kind of the way to start? What are kind of the first things to get in line to be able to establish that?
That's a good question. I think, first of all, if you can go and see one of the services that are open, in any format, that is, I think that's always really useful to get some kind of hands-on experience, speak to people, see what other people are doing, join NFOG. SIOG has got its annual conference, which is in Ghent in, I think, November this year, which is a really good snapshot at seeing what other people are doing. And then I think the other thing is find friends where you work. So find other people who've got similar interests, speak to your therapists, because even if you can't get a therapist in clinic, you need to know how these pathways work, and how you can work your way around them.
Do you think you need a geriatrician as part of it?
No, I don't think you do. I
Okay.
think geriatricians have a huge amount of wealth, and in no way do any of us profess to be geriatricians. But I think it's that thing of, A, geriatricians are so in demand at the moment, and B, any kind of increased clinician time is expensive. So I think it's all about, we need to use our geriatricians, but we need to use them, A, for super specialist services, and B, to upskill the rest of us.
Yeah, I think it's difficult. Nobody has any money. So I guess pick a small group, so pick a targeted group, and collect the data. And if I was to, I should put Kirsty on the spot and see which member of the AHP team she would pick. I would pick a dietitian because there's trial evidence supporting the benefits, survival advantage of a dietitian alongside standard of care in esophageal cancer. So that would be my choice. I'm not sure what Kirsty would choose.
Physiotherapist.
Physio.
Yeah, also evidence now.
Yeah.
Yeah, and I think actually we've had times at Chelsea where it's amazing how quickly we've had various, changes in staffing. It's really interesting how quickly people can start to cross cover for other people once you've seen people do things a few times. Actually, our physio's been doing our OT's role as well. Our CNS is doing a bit of pharmacy screening. It's easy once you've started to pick up patterns.
Yeah.
And I was
I
going to
was
say,
just going to
sorry,
say,
I was just
go on,
going to say, I
Mark.
think that highlights the needs of the different tumor subgroups. Because yeah, so my GI population need dietitians, whereas Kirsty's prostate population need more physio. So it's very much dependent on your tumor site as well, as to what your needs are primarily. Sorry to interrupt.
No, and you talked, both of you, a bit about some of the things that perhaps a patient think are important and will go to their GP about, that is not always kind of cross covered. How do you think we can integrate that? Because again, we talked about geriatricians being overwhelmed. I think we're all very aware that we send clinic letters and ask GPs to initiate treatments or continue treatments that perhaps I don't know if we should be doing ourselves, or it should be more integrated. How do you keep that communication up? And is there a way that you've involved GPs or allowed them to, or not allowed, that's incorrect, engage them in supporting the service?
Yeah, I think that's a really key question, and it's something that's definitely been nearer the front of my mind more recently. So, for example, the rapid diagnostic clinics are often GP led, and have lots of GPs in them. And I think we're probably missing a trick in geriatric oncology. So I know that Kirsty have a GP there, but I don't know of many other services that do. I think we need to get out of the because I think this is not mutually beneficial in any way, but sending a GP a letter with an action list at the top is not in anyone's mind satisfying clinically. I think one of the initiatives that was great was I think it was down in Wessex. They found funding basically for a community cancer nurse who essentially went and saw all of the that kind of areas, patients with a cancer diagnosis in the community. They did all of the cancer reviews that came with Quaff Point, so the GPs were delighted. She was an excellent link between both the community teams and the hospital teams, and obviously the patients were delighted because they had someone who came to them and then they had a point of contact. And I think it's things like that we probably need to be looking at to learn lessons from and see where we can develop them further. I come back to the cost angle. And I think it's all about how we can work together. I think the key thing for any service that's starting up now is, unfortunately, quality isn't the most important parameter in terms of funding. It's all about cost savings. So I think things like that and working out how we can save costs together. And the other thing that sprang to my mind when we were talking about costs is Mark and I were at a meeting last week, and there was a service that had started looking at specifically, they brought in a geriatrician to sit in a renal oncology clinic. And basically, they'd managed to save £20,000 over 6 clinics just by reviewing actually who of these patients didn't need 10-year follow-up and who it was not useful to have surveillance scans for. So I think it's within wherever you're looking, within your tumour type or within your group, looking at where are the cost savings for that specific situation.
Thank you. Yeah, and I mean, there's just another comment from Benjamin on the chat, just saying how much he's enjoyed the discussion, and he's just saying, you know, we had the Persephone trial in breast cancer, which was 6 months of Herceptin versus a year, which has proved to be non-inferior. But again, there's just so much other new stuff coming out. It's just been completely replaced by everything else. And agreeing with you both that we need more academic trials to de-escalate in older adults, and I think that's a key thing. It's just they're all academic trials and the money has to come from somewhere, doesn't it? But yeah, I think it's valuable, and I think there's a really strong reputation in the UK for good, well thought out academic trials. We just need to keep pushing for them, don't we?
And I think Benjamin's highlighted a really good point there, that we as oncologists, well, I know you always feel that more choice is better. And as everyone, you know, every next line of treatment comes up, or the different types of treatment become available, you feel kind of happy that you can offer that to patients. But in the context of particularly, you know, our older age patients, it is really important that we are just thinking really specifically about whether it will be advantageous to them and specifically that individual. And I think you both highlighted that it is very much specific to the individual and their cancer type. It can't be a kind of a one size fits all model at all.
Yeah. And I think as well, I mean, I've just moved on to breast again, having come back to it. And I actually can't believe how few triple negatives in the curative setting they're giving Pembro to, compared to when I was there first time around when they were all getting Pembro, because it was Pembro and it was exciting. But I think it's just showing a lot of, we can do something. You know, it's not always right to do something. And actually, I think that although it's available, it's not necessarily always the right thing to do. And it really is those older populations that we're really considering a lot more about toxicity and is it worth those added benefits? Definitely. And yeah, there's nothing else on the chat from us. So if you don't have anything to add, Lucy, I think we'll close.
Yeah. No, a big thank you to both. Incredibly informative and just really applicable to our everyday practice. So I think, you know, I think you've already said that we can share some of those documents. That'd be very useful. And I don't know if you both would be happy to be contacted by people if they're interested in looking at service development, perhaps. Really grateful for your time. Thank you very much. And thank you for everyone attended. We hope you have a lovely rest of your evening.